So good morning, everyone. My name is Sile Toland. I'm presenting a case on a 36-year-old lady who was referred to our rapid access lung clinic following an episode of a moderate volume haemoptysis. This occurred 2 weeks before her presentation to clinic. This lady was generally well. She had no past medical history. She was a never smoker. She had no family history of note, and she was on no regular medication. When she was reviewed in clinic, she was clinically very well. Examination was normal, and she was vitally stable and was saturating normally on room air. Her GP had organised a chest x-ray at the time of the haemoptysis, and what we can see in that is just this ground glass opacity in her right upper lobe, otherwise normal. So at this time of review in clinic, in terms of what the differential diagnosis was, I guess the first differential diagnosis, and this would count for any case of haemoptysis, would be that of infection. It is important to note that her bloods were perfectly normal, including a vasculitic screen, her coagulation profile. However, this did occur 2 weeks after the initial episode. I guess we always have to think of malignancy when a patient presents with haemoptysis. However, this lady was 36 and she had no risk factors of such. And then this could be something a little bit more weird and wonderful, such as a pulmonary vascular abnormality. So just a little bit about haemoptysis for the general physician. So when we see a patient present with haemoptysis, it can be quite a frightening symptom for both the patient and the physician. And it's important to go through this in a systematic approach. And the importance of history taken in clinical examination has to be stressed in these cases. And then to perform an initial chest x-ray, if you think this might be an infection, it's reasonable to treat with antibiotics with a repeat imaging. If it's resolved, then that's fine. If there's any persistent abnormalities, the patient would usually want to have a CT thorax and then plus or minus a bronchoscopy. But if there is any sort of queries at any time during the management or the approach, it is important to involve a respiratory physician at sort of your earliest convenience. So our patient did go on to have a CT thorax just because it wasn't very clear exactly what the cause was. It's important to note that this CT thorax occurred 2 weeks after her clinic review, so which was 1 month following her first presentation of haemoptysis. And of note, before the CT was performed, she actually had a further episode of haemoptysis the day prior to this. What we can see is this area of dense ground glass opacity in her right upper lobe, which is consistent with where it was on the chest x-ray at the first presentation as well. Following this, because she had recurrent haemoptysis, she had a bronchoscopy. During the bronchoscopy, what we could see was just some evidence of old blood in her right upper lobe, some clotting, and the biopsies just showed some epithelial hemorrhage, but her histology was normal. It didn't show any abnormal tissue present. 1 month later, she had further episode haemoptysis. What we can see is again a ground glass opacity. It's less dense on this occasion. But what was important that during this time we asked her, took a little bit of more thorough history, and it turned out that these episodes were occurring on a monthly basis, on a cyclical manner, and they coincided with her menstrual cycle. So each time this lady had her period, she had episodes of haemoptysis. So following this, she was discussed at the MDM, her imaging was reviewed, but I guess the important thing was that history of this haemoptysis with her menstrual cycle. And it was felt that with this was consistent with a diagnosis of catamenial haemoptysis associated with thoracic endometriosis. In terms of the treatment options, these were discussed with the patient. Generally, it would be hormonal, but this was complicated by the fact that this lady was 36 and she wished to conceive another child. So she actually hasn't opted for any treatment at the moment, and these symptoms have proceeded for the subsequent 6 months. And she has been referred for surgical consideration given the fact that she doesn't wish to pursue hormonal therapy. So just a little bit about catamenial haemoptysis. So it's recurrent lung or airway bleeding, which is synchronized with the menstrual cycle. It's a very rare phenomenon, and it does pose a diagnostic challenge just given its rare presentation. So thoracic endometriosis syndrome, it involves the presence of endometrial-like tissue outside of the uterus, specifically within the thoracic cavity. So only 2% of extrapelvic endometriosis involve the thorax, and of these, approximately 1 in 5 cases involve the lung parenchyma, which produces catamenial haemoptysis. So just in conclusion, so catamenial haemoptysis is a very rare cause of what is a common presentation that we encounter on at least a weekly basis in the hospital. What this case stresses is that accurate history taking and timely investigations are key to her diagnosis. It also stresses the importance of multidisciplinary involvement. This includes respiratory physicians, obstetricians, gynecologists, as well as our radiology colleagues, and in some cases thoracic surgery. And just another caveat is not everything that one sees in a rapid access lung cancer clinic is lung cancer, and it can be sort of more weird and wonderful things. Thank you.
Well, thank you very much. Again, if we learn one thing from each of those cases, we'll be so much wiser. Professor O'Byrne, have you ever seen such case?
Thank you very much. First of all, wonderful presentation, and I can't resist saying that the presentations so far have been a terrific example of how to present a lot of information very effectively. All of us who have been in the business a little longer, as Roman says, should learn from these presentations. Very good. No, I have not, and that's the definition of a rare disease for me, something you read about in a textbook but never seen, and I've never seen such a case. Although in Hamilton there was one presentation, which I can recall, of a hemothorax in somebody that was catamenial hemothorax, so that is another obvious presentation of this. I wondered, given the very peripheral location of this, what appeared to be an abnormality, mass or density in the lung, was any consideration given to a percutaneous needle biopsy of that?
So at the time, just after she was discussed at the MDM, that was sort of the question was, could this be consistent with a diagnosis that we don't need to, I guess she's a young lady in terms of morbidity, risks of putting her through further investigations. And thoracic endometriosis syndrome actually doesn't require a histological diagnosis. So it was felt that we didn't need to pursue any further investigations at that stage. And then sort of in terms of biopsies, it's emerged that a VATS is the most effective way of biopsying these lesions anyway, which can then duly act as a diagnostic and a therapeutic approach, as you can sort of get rid of, or in other words, that endometrial tissue whilst also getting a diagnosis.
And the other question I had, given her decision not to accept hormonal treatment, was what are the risks associated with that? Does this ever present as massive haemoptysis that's life-threatening?
Yeah, exactly. So that's what she had to be counselled very thoroughly about that, because obviously the episodes that she had so far were moderate volume, but obviously we do know that other entities of thoracic endometriosis syndrome, as you mentioned, you've seen a hemothorax before, pneumothoraxes, and also she could have massive haemoptysis. If she's had one of these entities, it's not out of the realms of possibility that she could have any of the other possibilities. So she was counselled very thoroughly, and that's why she was then referred to the obstetrician so they could have a more in-depth conversation with her as well. And I guess also with the thoracic surgeon, whilst obviously the morbidity associated with putting this lady through thoracic surgery, given that it's only moderate volume at the moment, is just to stress the importance that if anything, if she were to develop more severe symptoms, that would be the treatment option then that we'd have to pursue.
Any?
Thank you.
Go ahead.
Can I start? Okay, good, thank you. So the interesting thing about radiology is that we get all the interesting cases from everywhere. And so I've been privileged to actually have been part of investigation of several patients with this syndrome too. And ground glass opacity is one presentation, but depending on how much blood is in the alveolar space, it can look like an air bronchogram, can look like consolidation as well. So there's various presentations. And one patient I recall with similar type of clinical desires that she didn't want to have this treated the regular route. Actually, we did a pulmonary artery embolization because of the degree of haemoptysis the patient was having. And that was successful.
Thank you. Just small question. Do you have his hair urine analysis, for example? Is there any hematuria?
No, she didn't have any hematuria. Her urine dipstick was normal, and she also had a vasculitic screen that was negative.
Well, thank you very much. Really great case. We are approaching.